El-Badri for paving the ground, let me say it like this. And I would like to share some of our results in cochlear implants and malformations. Can we just start the, thank you so much. And of course, I would like to highlight also the team of the Hearing Center in Freiburg. Without them, this work would not be possible, of course. We all know the classification of malformations going back to the description of Jagler and co-work is in '87, and also the adapted versions of Seneraglu in 2006 and 2010. So the special risks in malformations are, of course, the facial nerve, intraoperative gusher, and we all know that at least there are 20% of malformations in the childhood cases of cochlear implants, and they do have an increased risk of meningitis. So we want to make sure that they have their vaccination accordingly. So one of the most interesting things to think about in malformations is the choice of electrodes. And today we do have a lot of choices for straight short, straight long, or perimodular electrodes, either thick or thin. And we as surgeons, we have to find out about the individual anatomy of the cochlea and to find out which one is the most fitting for a shorter cochlea, for example. And we also think about the position of the neural elements within the malformed cochlea. So we might choose a lateral wall electrode rather than a perimodular in special cases, like a hypoplastic cochlea, for example. Now, in general, we can say, what are the Freiburg experience with malformations? There are, of course, no contraindication for a cochlear implant, and the prerequisite for a cochlear implant is the existence of an eighth nerve, of course. So what we do is a high-resolution CT and MRI preoperative, and we might use intraoperative imaging. We might use even navigation systems to verify the electrode placement. So we want also to prevent additional surgeries, additional imaging post-op, and this, of course, will reduce the costs on the long run. And for surgery in complex malformations, we can say they should be performed in experienced centers with all these necessary equipment available, like intraoperative testing, not only NRTs, but I do recommend stapedius reflexes in these cases, especially DVT or CT, and special implants available, of course. The outcome is, in general, favorable because the majority of malformations are mild, like the large vestibular aqueduct, as described by colleague El-Badri just in the presentation before me. But the more complex the malformation is, the poorer the outcome will be, for example, like in Charge syndrome. Now, I would like to show you a case, a special case with my favorite of malformations, because it's so special. This case is a young boy, 2 years old. He had surgeries in another clinic, and he was then presented to our clinic. He received a right cochlear implant in 2011. Intraoperative X-ray showed everything was fine. And they had positive auditory reaction post-op, so they proceeded to another implant on the second side just 3 months later. No auditory reactions on this side. So they decided to look at the file again. They had positive NRTs. They had no stapedius reflexes. They had a huge intraoperative gusher, which they managed. And then they did a DVT. 1 year after the second surgery, 1 year after no auditory stimulation. And what you can see here in this example is, actually on the right side, you see a contour electrode. Is this working? Can you see it? Not really. So I tried with a mouse here. On the right side, we have the internal auditory canal here, and we have a contour electrode within the internal auditory canal, misplaced. On the left side, you can see here and here an electrode within the internal auditory canal. So on both sides, we have a malpositioned electrode, and what clearly shows us that a plain X-ray sometimes is not sufficient. Because especially here you see a nice electrode, and if you do the wrong angle in a plain X-ray, it looks good, but it's wrong. So you might need a CT or a DVT post-operatively. And in this special case, we have an incomplete partition type 3, X-linked deafness syndrome. And I'm very grateful Dr. El-Badri described it very nicely. And what you can see is that there are some special features in this kind of malformation that I would like to look at. There's no bony separation between the cochlear base and the internal auditory canal, and that is a surgical problem. Because if you open up the cochlea, you have a huge gusher. Okay, you don't see anything for a few minutes, and then you lift the head up, wait a little bit, and then you can proceed. Okay, and the risk is that you directly implant into the internal auditory canal, and you have no idea about it. And you see here the MRI also is typical. So it's a very clear characteristic in the CT scan that you have to look at. Now I would like to share with you some of our results regarding X-linked deafness syndrome in Freiburg. So we looked at the charts retrospectively, and we had 9 X-linked patients within 1999-2014. And we looked at CT, MRI, all the things, and we also formed a matching group to compare these data with actually 9 patients, 3 patients each for each patient with regular anatomy, same sex, same age at implantation, and so on. So we have here a group of 9 X-linked deaf patients, as you can see on the left column, 9 male, of course, although in the literature there's a family described with girls presenting with the same X-linked deafness syndrome, but that's extremely rare. These were the mean age of 25, between 7 and 56 age in years. We had 7 implantations on the left side, 2 on the right side. We had 1 contour advanced electrode implanted in 5 patients, a 24M custom device preformed in 3 patients, and a 512 contour in 1 patient. Number of surgeons 4. 1 patient needed a revision surgery because of an insertion into the internal auditory canal in our series. The patient I showed came from another clinic. And the matched patients had similar characteristics. So I would like to show you some post-op results in these patients. And this is a very typical thing that you see in IP3. You have these wave-like TNC levels, which is absolutely characteristic in this group, and you will never find it anywhere else, due to the missing bone between the cochlea and the internal auditory canal, obviously. And here are mapping results in these patients, and what you can see is left side X-linked, here is a matching group. This is the first fitting results, everything looks fine, and please have a note on the blue line here, which is a pulse width. The pulse with a stimulation in this group of patients. And this is increasing over time, so after 3 years, we have here a pulse width in a mean value of 60. It goes up to 9-fold. That means the current needed in this kind of patient is extremely high, changes over time, over the first 3 years, and then seems to be stable. The mean time that we looked at these patients is 9 years, up to 16 years. But still they have a huge difference in pulse width when compared to normal patients. Results in speech test are a little bit poorer in these patients. These are sentence tests, approximately 40% to the matched group, 60-something%. And this is a children's test, 56%, and the Göttinger sentence test, 68%, but it's not a significant difference. So, what are my points about X-linked? Reports on outcome in this group is extremely rare. Mostly it's only case reports. The major concern in surgery is the CSF leakage requiring revision surgery, of course, but we were able to manage this in 1 surgery in all of our cases. There is a risk of insertion into the internal auditory canal, as I showed you. 1 case of our patients needed revision surgery as we had an insertion into the internal auditory canal. Now, what about the choice of electrode? A lot of people say just take a straight one, others say take a preformed one. Levenson or Rockler says take a shorter, straight one. I personally say take a contour advanced electrode. Why? Because you have a guidance of the electrode, and then do everything wrong. make a more superior cochleostomy, turn the electrode tip upwards so it will not go downwards into the internal auditory canal, but upwards into the cochlear base actually. And that worked out fine. And I need just one slide more. Let me continue, please. Thank you. The long-term results may be poorer, and it's interesting for the audiologists that they do need a higher pulse voice, up to 9-fold, which is really a lot of more of current needed for stimulation, and the reason might be a loss of neural elements over time. And the last thing I would show you the outcome of this patient that was sent to us, and actually because the surgery was more than a year, it was 2 years ago when they finally sent this patient. Actually, in 2013, I cut the electrode at the cochleostomy. I inserted an electrode into the cochlea, which you can see here, and then we ended up with an implant here, completely inserted into the cochlea, and this electrode left. I was a little bit afraid about fibrosis in the internal auditory canal, so I just cut it, and this child is doing well. Thank you very much. Shukran.